So welcome again to another episode of IBD Essentials, and today it's my great pleasure to talk with Silvio Danese from Milano, Italy. We are just meeting shortly after the UEG week, and just to start with one of the highlights, Silvio got elected as Vice President of UEG and will be the incoming President of UEG in 2 years' time. But this is not to talk about UEG, it's about innovations in IBD and IBD therapy. And Silvio is, as always, very active and presented multiple data. And I think today we'll focus a little bit on innovations on ulcerative colitis, and most likely, perhaps we start with a completely new mechanism, the drug Obefazimod, which is ongoing phase 2 trials we're seeing over the past years, but this year we are getting to the next phase. We are getting into the phase 3 trials, and Silvio was presenter of one of the 2 presentations here, but he also knows the other presentation, and I think this is a very exciting topic. But first of all, I think you should introduce yourself a little bit, and then you tell us what is Obefazimod at all, about the mechanism, because this is relatively new and will probably take some time to get into the clinic.
So thank you, Axel, and thanks to everybody that is watching or listening. So my name is Silvio Danese. I work as a gastroenterologist in San Raffaele Hospital in Milan, and it's very exciting because Obefazimod is a Mirna. What is a Mirna for the practicing gastroenterologist? Is basically a piece of RNA that is controlling some sequences and is able to block in the cytoplasm the excess of RNA that will be traduced into proteins. And this unique Mirna of that Obefazimod enhances is able to block the inflammatory cytokines, including all the inflammatory cytokines of STAT3. So interleukin-6, TNF. So it's like one drug that blocks many cytokines at the same time. So this is the first interesting aspect. So we are giving an immunosuppressant, but the data so far don't tell us that this is an immunosuppressant. So this is quite interesting. So there were these APTEC programs, the registration trial phase 3. At UEG, we have just shown the induction data at 8 weeks, in which 2 doses were tested, 25 and 50 milligram versus placebo, and all the endpoints were met. So this is exciting because one pill, this is important, it's oral, one tablet once a day was able to induce successfully at both doses clinical remission, 25 and 50 milligram, and then all the endpoints of endoscopic improvement, histology, symptomatic remission, everything was positive. So this is overwhelming. The second aspect that was quite interesting was that it works not only in the patients bio-naive or advanced treatment naive, but also in the patients that have been exposed to multiple lines of therapy, including many lines of therapies like 5 lines or JAK inhibitors. Of course, the highest dose is the one that is most effective. So this is the overall efficacy. Safety, 8 weeks is a small period of time to draw any conclusion, but in 8 weeks, nothing except headache. Headache was in the first 2-3 days, and this is transient and did not lead to study discontinuation. So I think that the induction was good. Let's hope, we cross fingers, that also maintenance will be good and this will be a drug for our patients.
Let's go a little bit into the details. Going back to the Mirna, the pathway, is it the first indication where the substance has been tested, or has it been used in other inflammatory disorders? Do we have some background data?
No, only first time that is used in ulcerative colitis. I think there was some activity. They were testing this in HIV, but then they didn't pursue this indication. And at the beginning, there was a lot of unknown activity in inflammation, and then I don't know why it was tested in ulcerative colitis. And then
Yeah, I can also recall that just talking about this, about the phase 2 trials, there were some initial data on patients with HIV, but it was not as successful as expected. So UC is one of the indications. Do you know if, because we know UC and Crohn's is similar, is there also a program for Crohn's disease? Or?
Yes, they are running the phase 3 in Crohn's disease, is enrolling, and I think it will take time. As usual in Crohn's disease, it takes always a lot of time to get the studies completed, but hopefully it will work also for Crohn's, but we need to see the data.
Let's talk a little bit about the study population. So you already mentioned some patients failing several lines of treatment, so it seems to be a very tough patient population. Any data about the duration of disease? So was it late line disease and the disease activity?
This is a good point. Classical moderate to severe patients, mean disease duration around 8 years. So, but the interesting thing is that half of the patients, generally when patients are recruited in clinical trials, they can fail maximum, to be generous, 3 mechanisms of action, because these are the most difficult patients, are the difficult to treat patients. And when we enroll these patients, it's always the worst patient population that will respond always low and low and low to any treatment. In this case, it was open to any type of patient. And the interesting aspect was that particularly even the multi-refractory patient got the same level of response, particularly for the hard endpoint over time. So this was quite good.
So you mentioned already the endpoints, and in the more recent trials, we see very tough endpoints. So beyond what we have done before, clinical response, clinical remission. I think as a clinician, it's always interesting to see what happens to steroid use. So did they also test steroid-free remission? And you already mentioned the more objective and very tough endpoints like endoscopy, histology. Is this in the program as well?
So regarding steroids, while we have seen only with JAKs the attempt to take out steroids already after 2 weeks. In this case, they were a little bit more conservative. So for the induction, they kept stable. So we will see the steroid free, but only in the maintenance. That should be hopefully by middle of next year. The other endpoints, the tough endpoints, you are perfectly right that endoscopy, histology, or the combination of the two have been assessed. The bars of efficacy goes a little bit low when you take the population of the multi-refractory or of patients that have been failed 1, 2, or even more lines of treatment, but still over placebo there is some efficacy. So the good thing is that we can smell that if the data will be confirmed also in the maintenance, this is a drug that we are going to use for any line of treatment because of this perceived efficacy.
Mm-hmm. And you already mentioned safety, which 8 weeks is very short and will be more important in the later phases. But was there any signal? Because this is a broad-acting substance. You mentioned that all important cytokines are impaired. So was there already some signal with risk of infections? I think malignancy may be too short.
There were, at least at the induction, there were only 4 infections, like 1 abscess, 1 COVID, nothing. Mm-hmm. So at the moment seems to be very clean. Of course, let's wait to see the overall 1-year data will give us more information. But at the moment seems quite interesting.
So just to summarize this part, we seem to have a new compound which is very efficacious, very safe. It's an oral medication, just a pill. So a new option. Where would you foresee, given that it will be again positive in the maintenance trial, this new treatment in the treatment algorithm we have for our patient? And can you also perhaps, we know that this is not possible, we cannot compare efficacy of drugs, but how would you set it compared to other drugs?
So this is an excellent point, the fact that safety is very good. very likely, I have the feeling that monotherapy will not happen in the future. Very likely also this treatment will be combined with something else. But as you see so far, very likely could be used for any line of treatment in all the patients. One of the aspects is that they've shown, for instance, some data with Etrasimod in mice in combination, and there is a nice synergistic effect on cytokine patterns. So this could be, I know that is just one example of combination, but this could be where the future can lead. Let's wait for the maintenance, and then after that we will decide. But safety-wise, excellent.
Okay, I think this was a really comprehensive summary of this part of the trial, but there were several other important areas, and now we were probably talking a little bit more to the patients with moderate or severe or even more severe disease. I think one thing we are still lacking is the perfect management of patients with milder disease, and I know you're definitely and heavily involved in the gladiator trial and the use of Etrasimod in also patients with more milder disease. We know, and we have been discussing this quite often, that this is tricky, and you coordinated also some initiatives. What is mild IBD? What is mild ulcerative colitis? Perhaps we should continue to discuss a little bit on this aspect. So first of all, perhaps you tell us how we define or what is mild ulcerative colitis, which patient population we are targeting here.
So this is interesting because until 2022, we were looking at endoscopic subscore up to 1, and then with Mayo score that was between 4 and 6. But FDA in 2022 gave specific rules to define what is a mild patient, mild moderate, or what is a moderate severe. A moderate to severe are patients between 5 and 9 points with endoscopic subscore of 2 at the Mayo score and at least 1 point of rectal bleeding. Mild moderate, there is a lot of overlap. This is the incredible thing, because mild moderate is between 4 and 6. Numerically, you see little overlap, but endoscopically, it's always above 2, which is a lot of patients in our practice, because we know that there is a part that is the symptoms that have a lot of variability and rectal bleeding of 1. So you see that there is very, very much overlap. But this was the definition of FDA, and of course, for a trial like Etrasimod that was already approved in moderate to severe, there was the attempt to perfectly match the inclusion criteria of 4 to 6 with endoscopic subscore of at least 2 points. This is the given. So in Gladiator, what has been done has been to randomize patients with mild to moderate ulcerative colitis according to these 4 to 6 into arms. Either Etrasimod fixed dose 2 milligram for 1 year or placebo. So treat through design and to see what happens to these patients. The primary endpoint was set at 1 year at 52 weeks, secondary endpoint at 12 weeks with a mixture between 12 and 52 classical endpoints. So remission, endoscopic improvement, endoscopic remission, histology, steroid-free. Now, the bad news is that at the end, the primary endpoint was not met. That means at 1 year, there was quite high placebo, and the difference was not statistically superior, was only in favor numerically with a 7% delta for Etrasimod as compared to placebo. At 12 weeks, the nominal p-value were positive. So now we can discuss what happened, what was the patient population, because it was very surprising, because the same type of patients were also present in the registration trial, in which there were many more patients and in which the trial was completely positive in this subset of patients in which the analysis was pre-specified. So this is quite relevant because we know that it works, but in the trial that was supposed to bring to clear evidence, it failed in the maintenance.
Yeah, as you are part of this trial, you mentioned already that in the registrational trial, this group was efficacious. Now we have the problem. Do you know any of the reasons? Was it because we know we have now global trials, were the differences in different continents, or was there something else that could be identified or an explanation? And how do we end up? Will this trial be repeated? Will be just looking at the registrational trial? Because now we have mixed evidence. Because I personally believe short-term data are always valid, but we are treating a lifelong disease, and it doesn't help us if we are doing very well for 12 weeks and not for years.
So the first point is patient population was not so mild. Was patients with endoscopic subscore of 3 in quite substantial number, and with 20% that have been already exposed to advanced treatment, including JAKs. So this is, and 1/3 of them was on steroids. This is not what we always call a mild population. Second, there were a lot of dropout with a small patient population. So in reality, it was a small study, not powered really with all this dropout to show significance. But then these were the major, let's say, flaws with a high placebo rate. We know that this works very well in this population, but the study could not show the efficacy. I don't know if they will repeat it or not with a more powerful population and so on, but this is what happened.
But as you mentioned, there was a high placebo rate and the high dropout rate. Can you recall what was the reason for the dropouts? Was it loss of efficacy or adherence or anything? Or
it was most of the time worsening of the disease, particularly in placebo. There was much higher dropout, and also patient withdrawing consents. Some patients, even for there was the war, because it was during the war, so it was complicated to continue being in the study. And in fact, you see that there is, in the placebo, there are more patients dropping out as compared to Etrasimod. So you can see that there is an effect. But this effect was not meeting the criteria of efficacy.
Perhaps we stick just a few seconds with Etrasimod, because we also not here, but there is the use of Etrasimod in Proctitis, because I think, and you were also very active in the field of Proctitis and definition of Proctitis, and we know that most of our trials have excluded Proctitis. So some people believe that Proctitis may be even a different entity and not ulcerative colitis. I was always believing it is ulcerative colitis. We just exclude it because we're not really sure if we have infectious diseases, and we want to avoid it and want to, not to spoil our studies with this. But is there anything new about the use of Etrasimod in patients with Proctitis? Or
it's quite interesting that it was reported that for the very first time in a registration trial, Etrasimod was allowing Proctitis patients. Generally, these patients are excluded, and then we see real-life experience with Proctitis patients treated. And what was interesting was to see that the effect size was exactly the same than patients with pancolitis. And in fact, now many other programs are including Proctitis to have these precious patients, because, you know, one of the misperceptions in the field is that Proctitis is a limited disease and could be easily cured without advanced treatment. But we know that Proctitis is the reason for which patients have disability with bowel urgency, tenesmus, and this impacts a lot their social life. So it's very good that for the first time Proctitis has been picked as an unmet medical need and has had the first advanced treatment. Even in Gladiator, there were quite around 15-20% of patients with Proctitis, and also with these patients there was efficacy in the mild moderate.
I think you touched on a very relevant and important point. I think a lot of patients still believe that Proctitis is the small child of ulcerative colitis and it's easy to treat. But we have patients with significant impairment of their quality of life, urgency, high stool frequency, and it's only like 5 to 10 centimeters to treat this type of patient. And in these type of patients, for sure, I think all of us would be more reluctant to recommend proctocolectomy if we have such a small thing. And if we have severe ulcerative colitis, extended colitis, it's simpler. I think, therefore, we definitely have the need. Or
yeah, absolutely.
I'm wrong. Okay, I think one area we could probably briefly touch upon is the IL-23s, because we have seen at UEG also the presentation of the 1 year data of the ASTRO trial, so Guselkumab as subq induction. Is this something which you believe is relevant? Did you expect this? Will this change your practice?
Exciting news for our patients, because the subq induction is very effective. And what was new in the study that it has been reported is that it works irrespective of the advanced treatment status of the patients. So if the patients were responder or not responder, or have been exposed to advanced treatment, Guselkumab works very well. Of course, it works better in the patients that are naive, but in the advanced treatment exposed patients, it works much better.
Yeah, and again, I think we have seen that the maintenance dosing is not different. So you can give it every 8 weeks with 100 milligram, or every 4 weeks with 200 milligram. At least the parameters we were seeing now, and we will wait for the subgroup analysis to see if there is any difference. Both doses highly efficacious, and we have results. We know we cannot compare clinical trials, but if we compare it to Quasar, it looks that it even may be a little bit more efficacious to have subq, or I'm wrong?
Yeah, it's true. This is due to, but of course it's difficult to compare across trials. But the good news for our patients, and I always like to say for our nurses, is that they can start from the beginning with subq and get the same power and the same efficacy, because there is always this misperception that IV is better. But in this case, not at all. We will see hopefully very soon the PK data with drug exposure and so on, that probably will bring more value and more scientific reasonings on why we say the same degree of efficacy. But what I've heard is not data that I've seen, is that the data on drug exposure is very similar. So it means that the subq formulation has been very well done.
I think you again touched on a very important point. We were always believing that IV is, as we do it with antibiotics or other drugs, we start something very heavy and it will be much, much better. Here we have clear evidence that it doesn't seem to be better. So my final question would be, and I probably already got your answer, what are you doing in your clinical practice? Subq or IV or both? Or do you still see with Guselkumab a patient profile where you would start a patient IV and not subq?
Unless a patient is asking me specifically that he wants to come to the hospital to do an IV, for me it's always subq.
Okay. Any further things you would like to add before we come to a close? Study which was a highlight, or?
No, there are a couple of studies. I didn't see the details. They are going to happen tomorrow. One is the oral IL-23 receptor. I know that has been tested in ulcerative colitis is positive, but I don't know yet the details. Second one is oral alpha-4 beta-7 that didn't work. So I'm curious to see how are the details, but maybe this could be presentation for next time.
Yeah, this will be definitely presentation for the next time. So I think this was a very good conclusion of our discussion. I thank you so much, Silvio. It was always a pleasure to discuss about these different findings, and for sure we will invite you for future presentations as you're so active. I'm looking forward to this discussion. Thank you so much,
Thank
Silvio.
you.